Good evening to all. I think we can start now. Friends, today we will be discussing about my clinical experience about dealing with the malignancy from Ayurvedic point of view. Of course, the concept of malignancy is something which has seen a huge change now. Definition of tumor when we were studying quite early was something different, and as it is defined now, the definition seems to be significantly different. The definition which we used to study in the beginning as a bit complex statement like a tumor is an independent growth with atypical arrangement having no useful function and termination. But now the definition is changed, that the current definition accepted by the American Cancer Association is a large group of disease that can start in almost any organ or tissue of the body when abnormal cells grow uncontrollably, go beyond their usual boundaries to invade adjoining parts of the body or spread other organs. The basic issue is now it's not considered as a single disease, it's considered as a large group of disease, whereas earlier tumor was considered as a single disease. That's one of the important issues. So tumor now has become a syndrome than really a single disease entity. Now, to make the diagnosis, the final diagnosis of any tumor or identification of any tumor or malignancy is based upon the microscopic findings. The pattern of the changes in the cells are the criteria to decide whether any tissue has become malignant or not. Now, the question comes in like whether our textbooks, Charaka, Sushruta or Vagbhata, would have mentioned about malignancy as such. I would say impossible. Impossible because at that time there was no question of a microscope. So defining the cellular pathology, the division, the shapes of the cells, and then defining on that kind of a pattern would not have been possible in Charaka or Sushruta's period. That doesn't mean that disease of malignancy didn't exist at that period. Definitely yes, all the diseases were present. So naturally, perception of the disease, clinical course of the disease were identified at that period, and they might not have been identified as a single disease entity or single pathological entity. See now, at present, the pathological entity of a tumor is based upon a microscopic finding. You can see the changes in the cells, like the shape of the cells would be atypical, shape of the nucleus would be atypical, number of divisions undergoing is more than the normal. Then only we will consider this as a tumor or a malignancy. Now, this kind of a perception would never have been possible in Sushruta's period. So naturally, the perception of the disease would be something different. So naturally, we will be now trying to look at the resources in the text based upon which we can identify the disease tumor. Or when a patient of tumor comes to me now, of course we would make the diagnosis based upon the current parameters, but at the same time how I would perceive the same from Ayurvedic point of view, that's one of the very difficult questions. Now to come to that specific point, the theory part, the tumor pathology, of course, majority of the tumors, primarily the word tumor itself meaning the mass, but at present when you say a malignancy, it need not be that the disease should be presented as a mass. There could be many types of malignancy where the mass may not be felt, as in case of the leukemia. So the primary definition of the tumor now would be based upon the microscopic findings, not on the clinical findings. But if it comes to the question of clinical findings, majority of the diseases and are identified with the palpable mass lesions, and the palpable mass lesions with the similar character of the tumor pathology are described in Ayurvedic text as the arbuda. Of course, now in the colloquial language, arbuda is equated or considered as a synonym for tumor, which I don't fully agree. One section, one group of tumors may be identified as arbuda, but not all the tumors might not be identified as arbuda. If we do not consider this part, probably we will not be able to understand the disease process from Ayurvedic point of view. So one major group of the diseases where palpable mass is the presentation of the malignancy, they may be considered as arbuda. Definition of arbuda according to Sushruta is Gatra Pradeshe Kvachideva doshaha samurchitaha mamsam abhipradushya. But the clinical signs are a palpable mass, vruttam, which could be having a specified border, sthiram, a firm swelling, mandarujam, relatively painless, mahantam, a huge swelling, analpamulam, where it's indurated, the base is deeper than what you see, and chiravruddhi, which tends to take long time for a suppuration or progression, a slow growing, or maybe at times it could be fast growing, apakam, which doesn't separate. The most important two characters are the non-suppurative lesion and that firm swelling which is seen. That's a very characteristic of a neoplastic mass or tumor pathologies which are malignant pathologies which are presented as a mass lesions. They are considered as arbuda. Now, one of the important character of the arbuda is it doesn't suppurate or paka doesn't occur. The reason given by Sushruta is the navaka mayanti kapadikatvat medo bhutvat visheshatastu dosha sthiratvat grathanachya tesham sarvabudharnema nisargatastu. That dosha sthiratva and dosha grathana, these are the two forms of the pathogenesis. Now, if we go into the basis of the vyadhi, the vyadhi is defined as a dosha dusha samurchana. So, a combination of dosha and dusha. In the context of arbuda, the definition goes something beyond that, samurchana. Instead, there is a sthiratva and dosha grathana. Now, that sthiratva and dosha grathana suggests about a continuity of the pathological process which doesn't have a termination. So, definition of a tumor where we say that there is no termination, that's exactly what Sushruta has considered as a dosha sthiratva and grathana. So, arbuda is obviously one section of the malignant lesions which can be identified. So, when a patient of malignant patient comes to me with a mass lesion which can be palpable, definitely the diagnosis will be something around the arbuda, moving around the arbuda. Some of the variants of the arbuda which are mentioned in the Samhita, they are very characteristic of the malignant pathologies. Like in case of the Shonita arbuda, the characteristic feature would be the fragile tissues which are fragile and they tend to bleed, a tumor which tends to bleed on touch. The saraktabihi pidakabihi, that's the typical feature. Or a Mamsa arbuda where the surface would be fimbriated or finger-like as such. Or a Talu arbuda where the surface also would be having like fimbriated appearance and soft fragile surface, padmakara, that the surface would have a irregular surface. These are all the typical characters of a neoplastic tumor mass lesions as we study now, and they are mentioned in Sushruta Samhita. So, palpable neoplastic conditions, benign or malignant, they are considered as arbuda without any doubt about that. And they are over the surface of the body. Gatra Pradesha, that's Gatra Pradesha is over the surface of the body. But along with that, there are certain conditions where the mass may not be over the surface of the body, but mass may be palpated within the abdomen. And that abdominal masses like Gulma also may be considered as some variety of the neoplastic condition. So there is a difference between the Gulma and the arbuda. The Gulma is located in the abdomen and it tends to be movable. Hridbastyoho antare granthihi sanchari yadiva achalaha. So there is a movable. So some variety of the Gulma. I am not saying that all Gulma are malignant pathologies, but some variety of the Gulma could be presented as the malignant lesions where the patient would have the systemic symptoms as such. Then another presentation of the tumor pathologies or malignant pathologies, I would say the malignant pathologies would be a obstruction to the passages like esophageal malignancies which produce obstruction to the swallowing. Now, or maybe the pathologies of the prostate or so on, where the urethra may be obstructed, common bile duct may be obstructed, and so on. So, you identify a neoplastic condition based upon the evidences, either the clinical or investigational evidences of obstruction to the passage of the contents. Now, such obstructive diseases also are mentioned in Sushruta in different contexts. Among them, one is balasa. Balasa is a situation where the annagati, the movement of the food, would be affected, and you would have a circular swelling around the area. Karoti annagatim nivarya. So when the annagati, swallowing difficulty, is presented, and along with that there is a circular swelling, circular lesion, valayam or valaya like appearance. So balasa and valaya, these are the two variables conditions. Balasa is where the surface would be elevated, raised, a fungating mass lesion in the esophagus, and a annular lesion or a circular lesion is the valaya. So variants of the esophageal obstructions were described in Sushruta. Or similarly, the obstructive pathologies in the urinary tract, like Mutrashtila or the Mutragranthi. Mutrashtila is where a palpable hard mass is felt at the parrectal area, parrectally. So Shakran Margasya Bastesha Vayuhu Antaramashridah. In between that rectal and the urinary tract, the mass is felt, which is stone-like, Asthiravat Ganam, which is stone-like. So that's obviously the prosthetic pathologies. Again, it's not the question of benign or malignant. It could be the presentation of a mass lesion. Or similarly, in case of Mutragranthi, it's again a palpable mass, but the difference is in that Mutragranthi there would be pain, a painful condition, like maybe either the prostatics or some of the tumors of the prostate too can be painful. So that's evidently identified. Then there are a presentation of the tumor pathologies in the form of ulcers. Ulcerative lesions are another presentation of the malignant pathologies. Again, it could be either over the surface of the body, or it could be anywhere in the area, like in the stomach or so on. Now, Sushruta has described the varieties of the Dushta Vrana, which could be suggestive of the malignant changes, malignant pathologies, like Ativivrata, a wound which has become quite wide and the surface is wide as it continues to widen further. Bhairavaha, which looks somewhat some unappealing, like, and it produces some a fear feeling, like looks quite terrific. Or Utsangi Amanojna Darshana Gandha. Amanojna Darshana Gandha is the same, like, which appears, by the appearance itself, looks very wacky and suggestive of a possibility of the tumor. Utsangi, the surface could be raised and there could be multiple tracts or induration. Dirgha Kalanbandhi, which tends to persist for a chronicity. These also could be the evidences of the malignant changes in any ulcer. That's exactly the same. Now, whenever we have a very chronic non-healing ulcer, Marjolin's ulcer, or maybe the carcinoma, basal cell carcinoma, the clinical suspicion would be based upon these features only. Of course, the confirmation now, it has to follow histopathological background. So, histopathological backup. Without histopathological backup, it may not be possible to make the diagnosis now. Whereas the clinical signs of both the ulcerative lesions are described by Sushruta. Or the other way, in a typical ulcer, which is having an indurated surface and the edges are raised, that too is considered as one of the conditions where either the ulcer surface has to be curated or excised. And that's what Sushruta has mentioned, the characteristic feature of an ulcer, where the surface could be hard, it tends to disrupt repeatedly, or it may have a raised fleshy surface. That's considered also as a condition which requires either a lekhana, that's curating, or excision. Though Sushruta has not considered this as arbuda, I would consider a malignant ulcer as one of such vranas which require either the excision, chedana, or the lekhana, depending upon that. That's the point. So when we look at from Ayurvedic point of view, we have to consider the clinical presentation than the real pathology as such. Now, systemic symptoms of malignancy also are described in Sushruta in certain specific disease conditions, like Raktarbuda. In the Raktarbuda, characteristic clinical symptoms like Rakta Kshayopadrava Pedita, because of the lesion present over the area, the patient would have 𝐻𝐸𝐽 lakshana, that's anemic features would be presented, or there could also be persistent bleeding. These are the exact clinical description of a surface tumor pathology, the fragile tissue producing the lesion as such. So that's about the conditions which we can now identify based upon the clinical features as the malignant lesions with evident local signs or localized malignancy conditions. But there are certain malignancy conditions which are systemic now, like leukemias, and Sushruta definitely not has considered them as 𝐴𝐵𝐴. But the features of those leukemia-like conditions can be seen in the description of the pandu, particularly among the Asadhya lakshana of the pandu, and in the Asadhya lakshana of the pandu, the conditions which can present with the appearance of the very chronic condition, �𝐴𝐵𝐴, which becomes chronic and becomes resistant to the other features as such, and which also can present with the systemic symptoms like digdhangaha, ఛర్దిः, మూర్ఛా త్రిషార్దితः. These are the considered as Asadhya pandu. So a patient of leukemia with these clinical presentation, I would be considered them as one variety of the one or other variety of the pandu, either Asadhya or Sadhya, depending upon the situation as such. Or some of the leukemic features also could be seen as a dhatugata jvara. In the gambhira jvara, dhatugata jvara, the features mentioned are the same, like the patient would have svedha tivra pipasata, pralapaha, vami abhikshnashah. The patient would have a persistent fever and then sweating and then a loss of weight. Antardaha, the temperature would be, core temperature of the body may be raised, whereas the surface body feature may not be very much raised as such, and there could be multiple systemic symptoms including the marmacheda, consciousness also could be impaired. These are all the typical features of the dhatugata jvara. So some of the leukemic conditions, based upon the clinical presentation, I would be making the diagnosis of a dhatugata jvara depending upon the presentation. Either it could be a uttana dhatugata or gambhira dhatugata. Majority of the leukemias, I would be making the diagnosis of the gambhira dhatugata jvara. Now a pathogenesis where the disease doesn't end up and it tends to produce a sequence of the pathologies in the same manner, there the description is of dhatu anukramana, which is mentioned by Charaka. The dhatu anukramana is a very specific word. Like once a pathology has occurred, usually in the normal course, either that pathology would be having a paka, it will be having a situation of further progression, and then there will be paka or maybe the separation, and then the disease may be terminated, or it may result in a stigma, a vranavastu or can occur. But there would be certain pathology which can result in a dhatu anukramana. Dhatu anukramana is a disease process which has occurred in one tissue. It can present further, it can produce further progression of the dhatus which are of the same nature. The next generation of the dhatu also would have a same pathology. That's the dhatu anukramana, and dhatu anukramana is also considered as one of the causes why a disease becomes incurable or asadhya, and this is exactly the malignant pathology. So a malignant pathology described by Ayurvedic point of view is used by the word dhatu anukramana, where a clinical evidence of a pathological dhatu or tissue formation in the next generation is identified by clinical means. Whereas now we make the diagnosis based upon the histopathological evidence. We need a microscope. Without the microscope we may not make the diagnosis. Whereas Sushruta or Charaka had made the diagnosis based upon the clinical parameters. So naturally there will be some gap of identification of the lesion, some gap of nomenclature of the lesion, some gap in predicting the prognosis and so on. But the point is, the pathological process related to the malignancy were well described in the context of either the dhatu anukramana or the dosha sthiratva or dosha grathana. These are the three variants of the pathogenesis produced in case of the tumor pathology. Now, how these are relevant, I will come to that later when we discuss some more issues related to the malignant pathologies as such. Or another evidence where the disease process may not have a termination is also mentioned by Sushruta in case of the Shastra Kriyakala, the Bheda Kriyakala, where the Vranabhavam Apannanam Shastra Kriyakala, a disease may become reach a process where it becomes avadirna, it tends to disrupt or spread to the other areas, and it will have a Vranabhava. Vranabhava is Adeha Dharana, a lesion which will be remaining in the body as long as the person will live, or it may end up with the patient. That's the Vrana Bhava, and such a situation may occur, and that too is an evidence of the malignant pathology. In addition to this, the description of a secondaries produced also are described in the context of Arbuda. When a Arbuda produces another lesion of the same nature, which is exactly the definition of metastasis. The metastasis is described as a presentation of a similar disease entity elsewhere in the body. Now, Sushruta has mentioned two varieties of that metastasis. One is Adhyarbuda and the Durarbuda. Adhyarbuda is when a mass is generated over the mass, and hence the surface becomes irregular, as you see over this image, where a lesion, breast cancer, where there is a mass, and then because of the differential growth, you will have some more lesions which look like a mass over the other area, or a mass which is produced elsewhere, maybe in the axilla, as you see. That's the Durarbuda. So metastatic presentations are described as one of the possible variants of the Arbuda. So that basic pathology is identified. And when it comes to the question of management too, in such apaki rogas, the only possible choice of the cure is Chedana. It is considered as an irreversible pathology, and hence the indication for Chedana or the excision, the complete surgical removal, is the only possible cure. And Sushruta has given you all that complete description about the importance of the surgical excision. Like a disease which is presented as a firm and non-suppurative lesion, maybe that's what we have considered as maybe a tumor pathology, palpable tumor pathology. Surgical excision has to be done. Chedana is indicated. And when you do the Chedana in case of the Arbuda, you have to ensure that the disease is completely removed. Even if a part of the lesion is left over, then there could be recurrence. Sashesha doshani e arbudani karoti tasyashu punarbhavanti. A possible recurrence of the disease also was identified by Sushruta, and hence when you remove, you have to be very careful. Tasmat asheshani samudharetu. You have to remove the lesion completely as such. If at all a complete removal of the lesion is not possible by the surgical process, you may make use of alternative methods. Debulking therapy also could be possible as a surgical treatment by Sushruta, and that's maybe that debulking may be facilitated by natural entities like the krimi, maggot formation. Alpavashiste krimi bhakshitecha likhe tato agnim vidadita paschata. If at all it's not possible to remove the tumor completely, the same may be partially excised, and whatever the residual lesion is left over, it could be managed with the krimi, the natural evidences. These are the methods which are suggested by Sushruta. So the point is, almost the clinical course of the malignant disease and a basic clinical approach to the malignancy is described by Sushruta, which seems to be almost the same as we follow now. The only difference now is that you have some more details as such. Unfortunately, when it comes to the question of history of malignant lesions and neoplastic lesions, the current textbooks do not mention anything about Sushruta as such. All that history, if you read about the history in the contemporary system, it starts with Hippocrates, and unfortunately even all our Indian doctors, Indian textbooks also start with the Hippocrates mentioning of the word cancer, but the Sushruta or Charaka who have written about all that pathology in detail and a basic clinical approach, minus the microscopic details, only the microscopic details are not mentioned, but otherwise a very proficient clinical description of the pathology, a simple or a confident clinical approach to the management, These are done or assessed 5000 years back by Sushruta Charaka, and that part unfortunately is not included in the standard protocols of the history. But if you read the history in the contemporary situation, the history of tumor starts with the Hippocrates, who had used the word cancer because of the shape of the crack, like the lesion tends to spread. But Hippocrates could not really describe the pathology as such. He couldn't really make out the exact cause as such. All that he had mentioned is there is an incurable lesion which is considered as cancer. Then of course the milestones in the development of the tumor pathology, it started with the 450 to 370 BC by Hippocrates, where he had mentioned a similar pathology. Galen had mentioned a word oncos in 2nd century and bloodletting as a standard protocol of the treatment. But till 1775, there was not much of a significant change in the history of the tumor or tumor management from in the contemporary Western medicine, and this is a very important thing. Whereas Sushruta had a mature, methodical approach to the treatment of a apparently neoplastic lesion, whereas in the Western history, the pathology was not clearly defined, only the nomenclature and certain basic details like a bloodletting as a treatment are practiced as such. The possibility of a theoretical approach and a study, it came up only in 1775, where Percival Pott identified the chimney cancer, where the inflammation is considered to be a cause of cancer. Then of course somewhere the theories about the cancer developed. In 1863, inflammation was established as one possible cause for the cancer. In 1896, Hilario described inheritance of cancer, the possible genetic pathology. A major breakthrough in the approach to the management of malignancy came in 1903, where radiotherapy was introduced. Point is, radiotherapy was introduced as a part of the treatment only something around 217 years back. The whole history is 217 years, but at the same time, we have to appreciate the other part, the technology which has developed so fast in that 217 years. And we have a history of 5000 years, but we are not able to develop the technology to that level. That's the other part of it. Anyway, that's the other part. Then the other more and more concepts about the tumor pathology is developed later, and in 1909 it was immune system and cancer relationship was established by Paul Ehrlich, and in 1960 cigarette smoking and cancer, the relationship was established by 𝐿𝐻. Then the further real breakthrough came in only in the last century, that's the 20th century, 1920 and so on. The fast development of the growth and the assessment, particularly the approach to the malignant lesions and understanding the malignant pathology, had developed only in the last century, and it was only in 1920 that an experimental carcinogenesis was possible. In a clinical, in a laboratory condition, a malignant lesion could be developed, and from that day onwards, or that moment onwards, new developments have started very rapidly, and lots of new things have developed. And currently, in the last few years, the development is enormous. Lots of new information is added, lots of technology is added, and to follow all that technological changes is quite difficult and virtually not possible. Anyway, in 64, a virus was considered as to be a cause of a relationship of a viral infection and cancer, malignancy in Burkitt's lymphoma was identified. And the genes, again, this gene and specific subgenes like HER2 also was identified in 1984. The gene suppressing genes also were identified. 2014 is the situation breakthrough where a DNA analysis and cancer genome atlas was formed, and this is considered to be the latest of the development. Of course, to describe all the changes or all the developments in the past few years, it will never be possible. So I have tried to pick up certain of the major breakthroughs which have really are considered as game changers.